This conference will now be recorded.
Okay, Tracy. Good afternoon, everyone, and welcome to the final webinar for the 2014 Flex Conference webinar series on framing rural health value. And I am now hearing a little bit of an echo. Nicole, are you hearing that as well?
Not really, but I can remute all the lines quick since we had a bunch of people unmute their lines.
Okay, let's do that, and then I'll keep going.
Okay, give me a second, and then you're going to need to hit star 2 again.
Yes.
Okay.
All right. And welcome everyone this afternoon to the final webinar for the Framing Rural Health Value Series. This is Tracy Morton. I'm a program manager at the National Rural Health Resource Center, and welcome to the last and final plenary event for this webinar series. A reminder again a little bit about who we are here at the National Rural Health Resource Center. We're a nonprofit organization based in Duluth, Minnesota. We work on sustaining and improving healthcare in rural communities throughout the country. With Affiliation's leading knowledge and technical assistance center about rural health, and we focus our work in 5 different core areas. But on top of those areas of work, we also serve in a variety of different programs, many funded through the Federal Office of Rural Health Policy. And we have the great benefit and privilege of being the Technical Assistance and Services Center for the TASK program here at the National Rural Health Resource Center, in turn supporting the 45 states that participate in the program. So today for the webinar series, where I just wanted to review the overall learning objectives that we've been doing throughout the weeks of the series that have been going on since the middle of May. That sure does seem like a long time ago now, so thank you to everyone for sticking with it. We hope that through this webinar series, you've been able to explore how the core areas of the FLEX program can be supported by performance frameworks in this emerging value-based healthcare system that we're currently all navigating through. We hope that you've discovered how critical access hospitals and state FLEX programs can support activities that align with performance excellence frameworks, that you understand how the FLEX program can support interventions for financially distressed critical access hospitals on the verge of closure. And we've used a case study hospital as we've gone through this webinar series to help identify those points. And we hope that you've also expanded the awareness and use of resources that you might have or that you could identify to support your program and the critical access hospitals that you're supporting. Our objectives today for learning include understanding the importance and impact of the individual critical access hospital and the state FLEX program in framing rural health value, that we can review the recommendations for critical access hospital improvement that came out of the cohorts for that case study hospital that you all participated in, and that we identify actionable items for future state FLEX program work utilizing a performance excellence framework. At the end of today's event too, you all will be getting an electronic assessment that'll be about the whole webinar series in its entirety. So please take a few minutes to complete that. We know that this year was a different situation for us with hosting this webinar series instead of meeting face-to-face. So we're very curious about your feedback on how this webinar series went for you, how the learning was applied through these multiple month-long activities, how engaging in the cohorts might have been beneficial, what we could do better in the future if we're continuing to do webinars, and also distance learning opportunities like that. So please take a few minutes and give us feedback on that. Today our agenda includes quite a few different things. First, we'll review kind of the overall purpose of what we did with this webinar series and why we were doing it. We'll look at what that performance excellence framework again looks like. And then we'll move into a discussion by a panel of state FLEX coordinators reviewing the top 10 interventions for that case study hospital that came out of all of the cohort discussions. We'll work to identify outcomes then at the case study hospital 1 year later that were recorded into a final report that is just published today. And we'll review the relationship of performance excellence frameworks with critical access hospitals and the state FLEX program. So many things to do today, and 5 additional speakers on the line today aside from myself. So a review of where we've been since middle of May. There have been 6 plenary webinars like this. You've all participated in 3 application exercises. Each state submitted 1. There were 3 cohort conversations that each registrant participated in. A final report document was produced and, as I mentioned, published today. And after today's event, certificates of participation will be mailed out to each person participating in the webinar series. All in all, our measure of kind of engagement in the webinar series is that 67% of the State Flex programs completed all 3 applied exercises. We know many of you, and even many of you, had multiple people from your office participating in the cohort discussions, and we've always had great turnout on all these webinars in the live events, and we know that you've been accessing the recorded events too. So we've come a long way since May 14th when we started this, and thank you all for sitting tight and hanging with us, and we hope it's been beneficial to everyone. So the purpose of this webinar series was really to help us understand what's happening in the current healthcare environment and what we can do in our state flex programs and what we can do for our critical access hospitals that may be in some turmoil and jeopardy to navigate through this changes that are going on. And when we look at the current healthcare business model, it's really based on volume. And so in essence, the more procedures, the greater the interventions, the increased frequency on physician visits all result in more money for hospitals. And I don't think that's what really any of us got in this business to do. It doesn't mean that our hospitals and physicians are necessarily money hungry, but they're just operating in the way that the system was designed to produce high volume. And so as we've talked about before in the webinar series, every system is perfectly designed to produce the outcomes that it's designed to achieve. So we have a system of high cost, low quality, and in turn high chronic illness and low access to care. But we've also been talking about the triple aim and how that's working to improve the health of the population, enhance the patient experience of care, and reduce or at least control the per capita cost of care. And we're in the midst of transforming this healthcare model to make more sense and take a systems approach using a performance excellence framework like Baldrige to guide our work. And so what we've been doing then is talking about how integrating in this triple aim into the work that we're doing can work to change our system from one that's currently based on volume to one that's based on value. And under this new healthcare, I guess, environment that we're operating in, we're seeing some calmer waters from this storm that we've been, I guess, trying to function within in the healthcare system. And we're moving from this system of high cost and low quality and high chronic disease rates, et cetera, into a future business model that's really centered on the patient, where the value of the system is determined by a new formula that's quality plus service and population health, all divided by the cost, equating to patient value. And so this is things that we've been incorporating into our discussion throughout the webinar series. And we've suggested then in turn that in order to successfully navigate these changing waters into hopefully a calm lake or ocean ahead, is employing a systems framework to help us navigate and ensure that all of our systems and departments in our hospitals and our systems and areas of work within our flex programs are all operating simultaneously and in conjunction with one another, not in silos. And so a systems-based management tool is really required to help us align our focus on quality and performance both in hospitals and also in the state flex programs as well. So throughout the series, we've been talking about the Baldrige Performance Excellence Framework and how this really truly can be a blueprint for our rural hospitals in the times ahead. Last summer, we produced the blueprint for performance excellence that was, I guess, a blueprint as well, not necessarily a roadmap, but more of a blueprint for how critical access hospitals can really digest this framework. So I encourage you to all take a look at that, and we've been discussing that framework then further in the webinar series here. And what this framework can help us do, as we've discussed previously, is to reduce mortality and patient safety errors, increase our patient satisfaction, bring population health management into the realm of the critical access hospital, and have increased staff and provider satisfaction, increased revenue. I think all of these things are desirable in a workplace, and I think for us as folks involved with the state flex programs in a program that we're trying to support, one that's really more patient-centered versus one that's volume and cost-centered. So review then of what the framework looks like, and it has 7 categories. And each of these categories then we spent time on a plenary webinar discussing with a panel of experts, be it from a critical access hospital, a state flex program, or another national rural healthcare expert, about how the different criteria or the category really can be adapted into the critical access hospital environment and into the state flex program as well. And then in your cohort discussions, you spent time through your applied exercises, relating the information back to the case study hospital, and what interventions you might recommend to really help them get in their leadership, for example, in line. So in summary of the purpose of this framework is that first and foremost, leadership is really the utmost importance, and that leadership support is critical in helping the rural hospital stay relevant under health reform. And that leadership support is relevant in the critical access hospital itself with its critical access hospital administrator or other lead nurse staff, etc. But it's also leadership support coming from the state FLEX program and you as the FLEX coordinator or the FLEX program director as well. What are the resources and tools that you can align within your FLEX program and in your work plan to help support those critical access hospitals and provide them with the leadership that they need? The Performance Excellence Framework is a tool that can help support then the leaders of a hospital as well as your FLEX program and a system-wide improvement. And as we've mentioned previously, the framework is really flexible. It can be used in multiple ways. It's not a way of going from point A to B to C, but really a way for you to navigate and look at a structured approach to employing different areas within the 7 categories, but not necessarily having to do it systematically. You can, implement the different areas of activities that are best suited for your program, your resources, or for that of the hospital that are needed, but not necessarily a absolute recipe to follow. So please take a minute when we're done with the webinar today to resource and look up the blueprint for performance excellence as well, again, as we think that that's really a helpful resource for you to utilize within your programs and in your hospitals as well. I'd like to take a minute then, before we start reviewing the top recommended interventions and to have a discussion with our panelists, to remind you about what was happening at that case study hospital at Community Memorial Hospital. They had frequent medical staff turnover. It was they had independent primary care practitioners that weren't necessarily aligned with the hospital. The facility hadn't had any renovations since over 10 years. And there wasn't really a system or a network affiliation that was happening with that hospital. There was a network within the state, but they weren't participating in it. The board really didn't have a lot of training, and they had an inexperienced interim CEO who was relatively young and also the CFO. There were staffing shortages, turnover, and low wages and low benefits as well. They were struggling with their electronic health record implementation, and they had a lack of management and leadership training as well. Their key financials were direly below national medians, and they recently had some quality and infection control lapses. They didn't have any formal community needs survey or assessment, and they didn't have any formal process to get feedback as well from either the community or their patients. They had about 60% of their local population estimated to be seeking care elsewhere, and they had limited local healthcare provider interaction. So pretty much any area of the hospital that could have something going wrong with it really did. Not that everything was, completely in the pits because they were still open, but they really needed some help in pretty much all different areas. And as we discussed, is going through the framework, the different areas of the hospital all intertwine with each other, and a framework could really help them be supported better. So what happened then through the series is that FLEX webinar participants were asked to complete 3 applied exercises. And in the exercises, you identified different types of interventions that were recommended for Community Memorial Hospital to implement over the next coming year to maximize their effectiveness in all 7 categories of that framework. And in the applied exercises, you were allotted 10 points on each of the exercises to assign to the recommended interventions. And we didn't want to say that you had an infinite pool of resources, so that's why we really said you only have 10 points to reflect that in our FLEX programs, in reality, we have finite funding and finite resources and personnel as well. So that's why we limited it to 10 points. The cohort calls then that you participated in reviewed the point allotment for each cohort as a whole. And we had a discussion then on why certain interventions were assigned the majority of points and shared some best practices and lessons learned about actual implementation among your state FLEX program peers. Then what we did was, here at test, then we took all the points that were allocated to the interventions from all the submitted exercises and totaled them up and resulted in a top 10 list of recommended interventions that were ranked then from the highest point total down to lowest. And we put that recommended interventions then into a summary report that was released today, and there's a link at the end of the PowerPoint that we'll get to. But what we've done then is invited 3 of your Flex program peers representing the cohorts to join us in a discussion today to review the top 10 recommended interventions, why they were applicable to Community Memorial Hospital, and to share examples of the work that they've conducted in their states. So at this time, I'd like to introduce your peers to the call and ask them to press *2 to unmute their lines. So Susan Triggs is joining us from the Division of Primary Care and Rural Health in Virginia, Jay Kennedy from the Office of Rural Health and Community Care in North Carolina, and Scott Daniels from the Office of Primary Care and Rural Health in Hawaii. So welcome to you 3, and if you could press *2 to unmute your lines, then we'll move forward into our discussion about the top 10 recommended interventions. So what we're going to do then is walk through the top 10 recommended interventions here, and we'll just start with the very first thing. And not surprisingly so, it was in the performance excellence category of leadership. Top recommendation for the State Flex program that was affiliated with our case study hospital of Community Memorial Hospital was that leadership development and management education support was really needed to improve the overall Kirk-Alexis Hospital performance. So Scott, if you could let us know a little bit about some of the leadership trainings that you've provided in your state, that would be excellent. I know you've done some great work in Hawaii over the recent years on leadership development and management education.
Sure. Sorry if I'm a little scattered here. But one of the things that we've sort of realized over the years is that without having a good leadership or good leader basically directing all of this, and making it important for the hospital, that it was difficult to go anywhere. So we've been in conjunction with the quarterly quality meetings that we do, we basically have sessions that are set aside to do leadership, and then hospitals that have decided to go further with it. We've been using Studer basically to help create leaders and also for culture change. I know that gets talked about a little further on, but we felt that all of it sort of got encompassed in one. It falls under sort of the leadership. So we've been making it just a part of our meetings, any of our quarterly meetings that we have. That leadership is a part of everything that we do, and a lot of it, like I said, currently is looking at it under a Studer framework.
Excellent. Yeah, and I think you mentioned culture, but leadership certainly sets the tone for the culture that's going to occur within that hospital as well, so definitely related to that. How long has your group been working on leadership activities for?
Probably about 2.5 years now is when we started instituting doing leadership, and then Studer is a more recent development out of what we're doing for more general leadership type training and study.
Excellent. Okay. Yeah, and we'll talk more about Studer later on then, so hold that thought. Mm-hmm. Yeah, and I think that Community Memorial Hospital certainly, I think their leadership probably had good intentions or whatever, but some of their staff were promoted probably to leadership positions just because they were a good frontline worker and not necessarily the best in leadership skills or whatever. And then their interim CEO is young and is really trained as a CFO with minimal experience too. So developing that leadership as the kind of overall champion of the hospital could really be beneficial for this case study as well. And then Community Memorial Hospital was not affiliated with a health system, and they didn't participate in the existing critical access hospital network in their state. And the second highest ranked recommendation was for the case study hospital to explore partnerships with larger systems or rural health networks. And Jay, you had recommended an affiliation strategy for Community Memorial Hospital. Can you explain why you recommend that?
Sure. Thanks, Tracy. I have one of my critical access hospitals in the western part of North Carolina who are currently developing an affiliation strategy, so I've got some recent experience with that. They, much like our case study hospital, they're financially vulnerable and really identified probably 6 months ago that they needed to consider finding a partner. So I helped them find a consultant that they could work with to identify possible partners. They have a fairly new CEO who's been on board for, I think he came in January of this year, so he's fairly new. But he pretty quickly identified that they were going to have to find a larger system that could provide some needed help. They do have a management contract, a hospital management company out of state that's been providing management services for a number of years, but the new CEO has just not been very happy or impressed with this company, so feels like they need a stronger, closer relationship with more than likely an in-state, larger, not-for-profit hospital system, and or they might choose, I guess they could choose an out-of-state for-profit hospital system, but nonetheless, they know they need to find a partner. And another benefit, hopefully, of them finding a partner will be that they could get connected with a viable ACO. In North Carolina, it looks like our Medicaid reform direction is going to take us towards an ACO model. So that would all be hopefully tied in terms of them finding a partner. They could also connect with that partner's ACO.
Great. You know, and I've heard you say a couple of times the word partnership, and I think whether or not the case study hospital chose to affiliate or be part of a large health system or to be involved with an ACO or to stay independent, really partnership, I think, is what it boils down to, is that they need to not be operating kind of just out in left field by themselves and really need to connect in with one another. I know in North Carolina that you have some networks that share some data. Can you talk a little bit about some of the network work that you have going on in North Carolina?
Sure, and this is a fairly new initiative. We, in partnership with the North Carolina Hospital Association, have partnered with Truven Health Analytics, who have a small rural hospital product that we're planning to get our critical access hospitals to participate in a productivity management pilot project. So more or less, we've got 3 critical access hospitals so far who have signed on to this pilot project, and really the benefit will be that they will engage with Truven in reviewing departmental level productivity information. So for example, if your critical access hospital radiology department typically has 5 FTEs on first shift, but your peer group usually has 10 people on the same shift, you know you're potentially understaffed, or it could be vice versa, that you identify that you're overstaffed. So I think it's a really neat way for our small rural hospitals, the CAHs specifically, to help develop a data set for staff productivity that's really geared towards them. Because one thing I've heard, the majority of our CAHs in North Carolina are parts of a larger system, and when they're parts of a larger system, the mothership is typically a large tertiary hospital or a larger hospital, so whatever productivity data gets funneled from the large hospital down to the small CAH, it's typically apples and oranges in terms of how you staff radiology or how you staff the lab. So hopefully this is going to be a good way for our CAHs to have a good benchmark for staffing.
That's great. I like that. I like that, you know, they'll be able to network with one another and share kind of their thoughts, but also that they're sharing that data too, and sharing that data that's relevant to them versus coming down from, you know, a larger system or something like that too. And as the framework supports as well, looking at data management and what to do with that data and knowledge and is really important as well. So kind of some cross-pollination of the different categories of the framework here as well. And if we reflect back too, Community Memorial Hospital was really out of touch with their community. It was estimated that 60% of their service area population was receiving care elsewhere. And the cohort groups then highly recommended that Community Memorial Hospital prioritize the community health needs assessment. Susan, you've been doing a ton of work in Virginia then about community outreach and community work. Can you talk about why you would recommend this for Community Memorial Hospital?
Yes, because we have our Virginia State Rural Health Plan, and we have used it to engage our communities, engage our critical access hospitals, and encourage them to engage the communities that are part of their service area. As a result, we are like the Pied Piper marching on with, we've provided many grants to the critical access hospitals to be the leaders in their communities. And we were kind of nervous about that because we weren't sure that whether they would see that as an extra thing to do for very little money, because our mini grant was truly a mini grant. Well, as it turned out, they were excited about that and latched onto it and are creating their community engagement plans. We realized that the hospital, as I did the site visits, it was evident that hospitals many times worked in silos within their communities. And even though they knew the community sort of, many administrators were trying to, as Jay said, please the system folks or please their board of directors who often did not have the knowledge in healthcare that would help them understand the need for engaging the community or even being interested in doing that. So we ended up having to teach on all levels, you know, which is often what we do in this area of what we're trying to do. And, you know, teach the administrators that it's important to do this. And the population health management guide that was created was just phenomenal in giving them a picture of why it's important. You know, if the community, if you make the community a priority, then the hospital is strengthened. And it was easier to explain. Folks began to get it, and the hospitals began to engage around that. So we are developing plans. We've developed a Virginia Rural Health Advisory Board, which includes organizations like the State Hospital Association and different universities around the state, just groups of folks involved in healthcare that can come together, look at that community engagement plan, and it has to be aligned with not only Virginia's State Rural Health Plan, but the population health management guide that was the guidelines that were sent out. And in doing that, we are providing information to the hospitals. We're not, as community leaders, we're not saying that what they do is wrong, but what we're trying to do is provide tools for strengthening their plan, and they can do it or not. It's okay. But it's really becoming a statewide group effort to support rural communities. Our newest thing is because we only have 7 CAUs in Virginia, and we are looking to have 2 more that are going through the process right now. We had a hospital close, and the community got together, created an authority, and they are coming back as a critical access hospital, hopefully. But you know, we're guiding the state through, and we're asking the critical access hospitals to champion a sister community around the state, so that we can, you know, get support, and they can, you know, come out of their silo, come out of their box, and understand that the whole state is one big community.
Excellent. That's really exciting work. I love it how you have it all related back to your state rural health plan, too, and you're kind of using that as your backbone of what it is, and I guess, you know, helping support the mission and vision of your office, too, and the work that you're trying to do.
Yes.
So the fourth then recommendation that came out of the cohort discussions was back in the area of leadership. And some of the management, as I mentioned previously, and as was illustrated in the case study, some of the management at Community Memorial Hospital might have been promoted to their roles because they were just good at their jobs, maybe as a floor nurse, but they don't necessarily have any management training or any insight on current or future healthcare trends. And so the cohorts then recommended that the state flex programs provide education to the CH leaders, staff, and board regarding health industry trends and reimbursement models, quality, health service delivery, community engagement, and their potential impact on the organization. Jay, can you talk a little bit about the benefits that Community Memorial Hospital could realize from education on industry trends to their board and their CH leadership?
Sure. So I've been with the Flex program since February of 13, so about a year and a half. And when I came aboard, I started to have quarterly critical access hospital meetings, primarily for the purpose of having the CEOs, the CFOs, and the chief nursing officers to come to these meetings to share best practices and also have outside speakers around industry trends. So in terms of answering, I guess, this or specific issue around industry trends, it's been through these quarterly critical access hospital meetings with the executives that I've tried to bring in outside speakers to more or less try to keep them informed about what's happening at the state and federal level. Some of the recent examples have been at the state level, outside speakers regarding meaningful use within North Carolina Medicaid, and also a representative from the Medicaid leadership team about the forthcoming reform plan for Medicaid. So I feel like those meetings have served the executives well in terms of trying to keep them informed. One thing that I consistently hear from these folks, the executive level folks, that they appreciate the meetings that I have quarterly and the other email communications that I send out to keep them informed, because as you may hear from CAHs in general, they're on information overload, and they appreciate knowing that they have at least one source in me that tries to sort of cut to the chase and just tell them what they need to know. They get so many emails in a given day that I try to appreciate the fact that they're on that data overload mountain and try not to add to it and just try to summarize and synthesize some of these industry trend information that I receive and just forward it on. So it's a combination of doing quarterly meetings and then just periodic email communications.
Mm-hmm. Excellent. Yeah, that's great. And I think having that trusted advisor and you of this is either a really great speaker and I've brought them here to your attention because I think that they'll, serve you well, or these are the kind of the hot topics right now, reminders about things that are coming up to keep in mind. I think that's really important. But it does take building that relationship with your critical access hospital so they recognize the name Jay Kennedy when it comes across their email or the list of upcoming meetings that they have too. So it does take some outreach and maybe a little bit of time sometimes to build that relationship, but once you have it, then you really become, as a flex coordinator, that trusted advisor to your hospitals at your state.
And Tracy, I just want to add one other thing on here. As you mentioned, a lot of these people are promoted just because they do their jobs really well, and this also gives you an opportunity to sort of train people in the broader aspects of their job and other aspects of the hospital and how their jobs impact the hospital as a whole. So.
Yeah, absolutely, Scott. And from this hospital example, didn't seem like the employees had a lot of ownership in the work that they were doing. Maybe some of them did, but probably some of them are just showing up and going through the routine and maybe not realizing the impact that they have, or that they can make a difference in finances, or that that the finance work impacts the quality or whatever it might be. And so understanding what's coming up, helps people not be blindsided and kind of feel like they're up to snuff with things as well. That's a great point. And so Jay, you mentioned that, sometimes you bring in that outside expertise as a speaker about industry trends, but sometimes outside expertise can be helpful in providing processes or helpful in improving processes, particularly around finances and operations. And the fifth highest ranked intervention by the cohorts was for the State Flex program to assist Community Memorial Hospital in identifying potential areas of financial and operational performance improvement. Could one of the panelists please tell us a little bit about how your State Flex program has assisted the critical access hospitals in identifying the areas for improvement?
This is Susan. What we've done is, in Virginia, is bring the hospitals together. When I did the site visits, when I initially became the Flex coordinator, the overarching theme from hospitals was that they felt isolated and that they would love the opportunity to interact with each other and just to share information and gain lessons learned and expertise. So what we've done is provide two main opportunities, and one is a Virginia Critical Access Hospital Coalition, where the hospitals come together quarterly. This is a new thing, and at first the meeting, it was sparse attendance. But then at the second meeting, I was surprised at what happened, because not only did hospital folks, administrators attend, but systems administrators, because we only have one independent critical access hospital in Virginia, and all of the others belong to a hospital system. So the systems folks came, which was really exciting for me, because they were talking to each other, but we were also reaching hospitals in other states. But the hospitals began to identify the problem and then began to discuss with each other how they overcame the problem. So I didn't need to do a lot because they were doing it themselves just by bringing that forum together. It was a really nice synergistic way that they interacted with each other. The second thing that we're doing is on the 19th of August, we're having our first Southeast Regional Critical Access Hospital Financial Improvement Collaborative. And this is an effort just to strengthen critical access hospitals regionally and to share information. Some of our hospitals have done some really good stuff. And so we will be able to share that on a regional basis and talk to other hospitals and identify problems, discuss solutions, discuss best practices, build a knowledge base, just all sorts of good things.
That's excellent. So what I'm hearing you say from both of those different examples is that you're really bringing the hospitals together to interact with each other, and from their interaction together, then there's kind of self-identifying their areas for improvement and sharing their stories, sharing their data, sharing their lessons learned, and then from there, you probably as the Flex program then can really understand where to invest the resources and bring in that sometimes expensive outside technical expertise to really hit the nail on the head with, all of your hospitals, or maybe one or two of them that really need some support with some additional technical expertise.
Yes, exactly.
Very cool. Well, that kind of leads us into the next set of recommendations. They were both about different types of direct technical assistance that could be provided then to Community Memorial Hospital. So it was recommended that the State Flex program assist this case study hospital in direct technical assistance to evaluate their scope of services, physician hospital alignment, and market analysis. Could one of the panelists talk either about work you might have done on market analysis or scope of service assessment in your state? Anyone had that experience? It's not something that we see. I'm sorry, go ahead.
Well, I was just going to say in Virginia, in my experience, maybe not to that degree yet. What we've done is talk to hospitals about marketing and try to build that up as a necessary thing. We are really trying to get, especially the hospitals that are more isolated in a community but in a kind of out-of-the-way location, trying to show the the benefit of coming out of the walls of the hospital and going to where the community is. That's a process, and we're working on it.
Yeah, that's through, some of the work. Oh, sorry, go ahead, Scott.
I was going to say, yeah, marketing is one that I've always said that the hospitals need to do something better on, but we haven't done a full-fledged market analysis or anything like that. We've just provided some assistance on basically how do you get the word out on what you do, and make sure that that gets out to the community. Because one of the things we found out when we were doing the community needs assessment is the community would go, we want the hospital to do this, and the hospital going, but we do that, and I would go,
right.
And you have to get the word out that you do that to the community. So.
Right, exactly. And I'm sure that with this case study hospital, they're probably doing a whole bunch of different services, but if 60% of their community or their service area is going somewhere else, they're not sharing what they're doing either. And so, yeah, through that community health needs assessment process, hearing what the community wants, and then from the hospital's perspective, deciding whether or not they can provide that service, maybe they don't want to, or maybe they already are, and then kind of giving the why back to the community, or really raising the flag and saying, hey, we're already doing that and we're doing a good job with it. Come and see us here. It's really important and part of, their strategic plan as well. Then the other recommendation was for the State Flex program to assist Community Memorial Hospital with direct technical assistance on finances, business processes, quality of care, and patient satisfaction. So in short, they pretty much need to improve their processes, operations, and outcomes in all areas of their hospital. And Susan, I know in Virginia you've provided some financial and operational improvement assessments. Can you talk a little bit about what some of the outcomes have been from those assessments, if you've realized any yet?
We haven't realized any yet because we sort of started from scratch. When we started, or when I started as the Flex coordinator and did my initial site visits, the hospitals didn't know what Flex was. Even though they had been reaping the benefits of Flex, they didn't really understand what Flex was and how it supported them. They were happy to know that there was a grant out there that supported critical access hospitals. And they were also happy, because I'm so participatory, that we wanted their input on how we were going to frame the future work plan based on what they saw as priority for the hospital. But they have, the problem that we find is that the systems identify operations processes, as I think Scott said previously, and they're not always relevant to the critical access hospitals. So what I've begun to do is develop relationships with the systems folks, while I am also developing relationships with the actual hospital administrators. I want the systems folks to understand the importance of the critical access hospital, and to put it higher on the priority level within the system as a needed thing. I've talked to our new office director, who comes from another state, who had the experience in working in a small rural hospital, that the systems always use the small rural hospital as the pilot, so that the small rural hospital got everything first. In Virginia, it's exactly the opposite with our hospitals. Our hospitals are last to receive whatever it is. So, I see it as my mission to help the systems view the critical access hospitals on a higher level in the food chain, and work with them, before last, at least in the middle of the food chain. So we're working on that too. We're working on a lot of things here in Virginia.
Yeah, absolutely. Well, that's important though too, for especially in a state where there is so much system affiliation to make sure that, again, that the hospitals are recognizing the role that the critical access hospital plays in that system of care within that state, but also that the things that are happening in the big urban areas might not really be relevant for the critical access hospital that's part of their system, and that the resources that system might be providing might not be relevant either. Jay or Scott, do you have either of you have experience with providing financial operational assessments in your state?
This is Jay, just in the last couple of months, executed 2 contracts with 2 different CAHs for this type of work, but I don't really have any results yet to
Sure.
really speak to it.
How did you choose those hospitals?
Well, I knew of at least a couple of hospitals that needed some help, and then I just posted an RFA, a request for application, so that all the CAHs could apply, and we ended up having 2 to be awarded contracts.
Okay, great.
Yeah, and we've provided technical assistance on doing various business assessments and revenue cycle assessments for the critical access hospitals when we felt it's needed. And getting back to the system, sometimes it is difficult to get the systems to understand that work that they do for the critical access hospital can go on the critical access hospital's cost report. And so you can have your CFO of the system have some of that salary paid through the cost report. Yeah, I mean, yeah, it gets difficult sometimes working with the system and getting them to understand the importance of the critical access hospital. So yeah, there's a lot of work that gets done around on a system basis. And then like I said, for the critical access hospital in particular, we have provided various assessments on business and revenue cycle enhancement.
Okay, great. And I know revenue cycle came up as one of the recommended interventions too, so we'll talk more about that one here in just a little bit. The 8th highest ranked intervention was that Community Memorial Hospital work on developing a workforce that's change ready and adaptable. And there's lots of different resources that could be deployed at Community Memorial Hospital to support that Baldrige or Performance Excellence Framework, like we've been talking about throughout this whole webinar series, Lean, Studer, Art, Culture of Patient Safety, and Team Steps. Let's see. So, Susan, I know that in Virginia that you've been using the Art, Culture of Patient Safety and Team Steps. Can you tell us a little bit about why you chose to do those and how they're helping the workforce in Virginia's critical access hospitals be more change ready and adaptable?
They are tools that the hospitals seem to like. I discussed other tools with them, reviewed them by way of the blueprint provided by Terry and the Office of Rural Health Policy, but they seem to like these tools best. And so as long as they work, that's fine. And they can show the effectiveness of using the tools, and they've shared that information with us. So as long as they're being effective for the hospital, that's fine. We have one hospital that uses the balanced scorecard very effectively in terms of turning around deficits in operations. Finance is not a problem for this particular hospital, but operations is a problem. So, it's important to let folks use what they think is functional for them, because then they'll do it. We've really worked hard not to say, this is what you've got to do, and we believe it strongly, so do it, because they have to figure out what's best for their system.
Right. And you mentioned the balanced scorecard. One of the perspectives on the balanced scorecard is kind of a focus on your staff or your employees or your workforce, whatever it may be. And here at the center, we use a balanced scorecard, and then we cascade it into the task program. And one of the things that we do is focus on training and education among the staff here at the center and in the task program too, so that our workforce here at the center is change ready and adaptable, and is one of our core things that we focus on as well too. And that works for us here. One of the things that was really, I think, blatantly obvious with Community Memorial Hospital when we kind of presented the case study is that their financial house is really in dire straits. And it places their overall operations and their ability for the hospital even just to stay open in jeopardy. And so the cohort groups then recommended that the State Flex program assist Community Memorial Hospital in developing efficient business processes with a particular focus on revenue cycle management. And Scott, you mentioned revenue cycle management a little bit before, and I know in Hawaii you've been working on this. Can you tell us a little bit about your revenue cycle management program and what kind of success it's had?
Well, program? Yeah, no. Actually, what we've found is with the revenue cycle, and one of the reasons we focused on it is that in order to have an impact on it, you basically have to have all parts of the hospital have to be in alignment to make sure that the revenue cycle runs smoothly. So it's not just the business office has to be efficient. They have to make sure that the charges that they get or that the files that they get from nursing is clean and complete, and that the doctors have put in everything that they do. Otherwise, and if there's a chink on any of this, then it causes the whole process to be held up. And so sort of one of the reasons we focused on this is that we found that the people that do best on getting their days in AR, which is one of the gross AR accounts receivable, that we're one of the metrics that we're most focused on in this. The hospitals that were most effective in making a positive impact on that basically had a whole system in which they had weekly meetings which involved clinical staff and business office staff to identify where were the areas that they had problems, what can they do to solve those things, and basically it was something that the whole hospital was involved, and at the same time it was also quality. It helped to be a quality function. So that's one of the reasons we ended up focusing on revenue cycle for one of the things that we were doing. And then what would happen is part of our process of basically doing this is that the hospitals that were successful at the quarterly meetings, we'd have them present, what is it that you do? What did you do to get your revenue cycle down? What are the meetings that you set up? And then one of the nice things about our network is that even although they meet quarterly, everyone has everyone's number, and people will fly between the islands. They'll bring them out to go, you set up this revenue cycle process. Can you can you present at our hospital? So the hospitals themselves are acting as the experts on this. We just sort of got them together and got them thinking about it in the first place.
Excellent. That's great. I love the peer-to-peer learning. I think it would be at hospital or state flex program or whatever, we learn best when we're learning from our peers too. That's really neat that they're taking the initiative to do it themselves. And I like how you talked about how that it's not just the finances of the hospital too, but it's all their operations and processes, including quality, and having all the staff involved with that project really can help people, I guess, understand their role and how they can make a difference then in making their hospital and their workplace even better. And lastly, the cohorts recommended an intervention related to the workforce and culture category of the framework. And they really recommended, or you all really recommended, that Community Memorial Hospital create a culture that's patient-focused and customer-driven. And this really aligns with what's happening with our current healthcare environment. Scott, you mentioned earlier some Studer work that you've been doing with your network of hospitals. And could you tell us a little bit about, I guess, why the network and the hospitals chose to implement a program like Studer, and where you are to date with the project?
Yeah, I think the reason for Studer was that it seemed to be, well, one was the culture change aspect of Studer. So we did look at lean, but we didn't feel that, we felt lean was more quality tool that would fit in with Studer. So we're actually doing lean training too, but Studer we found to be at least for us, to be a package that impacted leadership, culture change, providing service, quality. So just for us, the way that we were viewing it, and the people that we were working with on it, we looked at a number, and Studer just seemed like the one that would work. It also helped that we had one hospital that had taken the initiative on their own to just do Studer, and so we were seeing some impact with them with the activities that they were doing with Studer. As for us, we started Studer earlier this year, implementing it with so we have 4 hospitals that are that have decided that they wanted to do Studer from the beginning. We started earlier this year. They've gone through 2 leadership development trainings, and we have plans for 2 more for the rest of this year. And we're currently talking about how we can provide this in a more efficient manner. Since we're in Hawaii in the middle of the Pacific, it can get expensive bringing people here. And so right now we're actually talking about, is there a way in which we develop basically the trainers here in Hawaii amongst people that already have some of the training to do some of the leadership development in the hospitals. So
oh, that's cool.
So yeah, and they're very amenable to that, and so we have some people that have already been trained and some people that have been partially trained that could use some more, and so they're working with us on basically doing that for the next year. So the plan is that we're starting with these 4 hospitals and monitor how well it goes, and so far it's been working well with them, and then as the other hospitals become interested, we'll start including them into the process also. Basically, we had, one of the 4 was one of the ones that started early on. So basically, these are the hospitals that decided that. And actually, we had 3. We're up to 4 now. Actually, 5 if you count the other hospital that's part of that whole system. But anyway, basically, as people see results, we expect them to join on, and that was always the plan, is that as we see results in other hospitals, that the other ones would want to join on. If the early adopters succeed, then the other ones will come along.
Yeah, excellent. Yeah, you're kind of starting that fire a little bit and spreading the the peer-to-peer knowledge, and then if you can have some documented outcomes or whatever to be able to share among the group, that's always moving. So cool. And I know you mentioned Lean too, and I know that in North Carolina, Jay, you've been using Lean too as a tool to help with culture change, particularly among middle managers. Can you talk a little bit about the work you've been doing there?
Yes, so we have a pretty long history of supporting Lean for our CAHs, and we've done that in partnership with the North Carolina Hospital Association. So this work precedes me. I've been on with the Flex program for about 1.5 years, but this goes back at least 6 or 7 years, I believe. Currently, we have 5 CAHs participating in 2 different Lean learning collaboratives. One of the cohorts, they receive Lean coaching from a university, and the other cohort of CAHs are receiving Lean coaching from a consulting firm that we utilize. Great return on investment and results continue to be seen, so I would really encourage Flex programs to consider Lean in their work plans. One thing I have seen recently is that with the turbulent environment right now for hospitals and their leadership teams, that some of their staff who have been working on Lean activities within their hospitals are getting diverted right now. One example is a Lean coordinator within one of my CAHs who was diverted to work full-time pretty much on their EMR implementation. So sometimes that happens is some of their Lean facilitators who are hospital employees get diverted, but I believe he's back on the job with Lean, so that's a good thing. In terms of the culture change, Yeah, I think the bottom line is you can't fully realize the benefit unless your middle managers, i.e. your department managers, are fully committed, and they really can play a vital role in the spread of lean, because it really has to become an organization-wide culture of lean and the transformation that you need to take in terms of fully implementing lean. If you don't, a lot of times what I hear is hospitals still view lean as sort of, well, that's the quality management department who's also now doing lean. If you hear that from a hospital, you know that they're not quite there yet. And it does take many years. We've got a number of hospitals who are now 5+ years into that journey, and they're pretty mature. But for some of them that are just a year or two into it, they're not quite there yet.
Sure. And here at the center, we've implemented some lean projects too, and I think it's such a neat system, I guess, because it allows you to see, really quickly, like a return on investment, or identify those areas of waste. And I think it really, among some staff members, can really start that fire of, this is really exciting, and I'm operating so much more efficiently, or I can get more done, or I have less red tape to work through, and really can kind of start to develop that interest. But you're right, it does take time to continue that spread throughout an organization, or to get everybody bought into continued process improvement and developing that culture, which then in a hospital environment could really impact that patient safety and patient focus and customer service excellence as well.
Also, doing culture change, you're always going to get some skepticism early on. We had it with Steward, we've had it with a number of things, but as if you have a few, that are willing to be the guinea pigs and at least hush that criticism and at least give it a chance, and we had that same process happening with Steward, and we had one hospital. My hospitals are, I love them because they're always honest with me.
Mm-hmm.
I had one hospital that told me, they go, I'm not sure what we're going to get out of this, and now they love they love the process now, but they were honest with me. We're not sure, we'll do it, but we're not sure what we're going to get out of it, and now they're one of the better performing hospitals that we have. So.
Excellent. Well, thanks for sharing that. Well, I'd like to thank all of our panelists then, Susan, Scott, and Jay, for reviewing the top 10 interventions with us and for sharing all the neat work that you're doing within your individual State Flex programs to address these similar interventions in your state. And thank you to all of the participants, too, for participating in that cohort process and applied exercises. These top 10 things really are what came out of your notes and your thoughts and your discussions in those cohort environments. There is a question in the chat panel, so I'd like to kind of bounce back to that quick before we move on to the next section. But Don Wood in Utah is asking if Jay could please describe how he measures his return on investment for lean, or exactly what measures you're using. And that might be a pretty specific question, so because I know you're doing a variety of different activities, Jay. So maybe that would be best. Jay, could you shoot me an email kind of describing that a little bit, and then I could share that out with the group and with Don?
Yeah, I'll do that. That's probably the easiest thing to do.
Okay.
I can do that.
Great, thank you. Okay. So now I'd like to invite onto the webinar Paul Moore and Christy Martinson from the Federal Office of Rural Health Policy. And they're going to be discussing from their perspective why a performance excellence framework is so very beneficial to critical access hospitals and to the State Flex programs. So first I'd like to welcome Paul Moore, Senior Health Policy Advisor, pharmacist, and a former critical access hospital administrator, to the webinar. And Paul's going to share his perspective about why the top 10 recommended interventions are really beneficial to a critical access hospital like Community Memorial Hospital, and what a performance excellence framework can do for a CH or a State Flex program. And Paul, I'll just advance the slides for you as you had sent a couple in to us.
Excellent. Thank you, Tracy, so much. And I want to just second your appreciation you articulated to Susan and Scott and Jay for sharing their experiences from their states today. And I especially want to thank everyone on the call who served as a part of one of these cohorts for your good work on this. The benefit of the team effort that has gone into working with this case study was evident to me as I read the summary report. Now, speaking of that case study that was published today, Tracy asked that I look at this summary report not as in my role as a Fed, but to put on my old CAH administrator hat, and I just got to tell you, that was not hard to do. Just a few lines into this case study, I was having flashbacks, and I was thinking this case study was very realistic, and it didn't take me any imagination at all on my part to see numbers of hospitals out there just like this in the same case with maybe not all the problems that this one had, but many of them, and it took me back to my own experience. And so with that as background, I just want to share just a few quick thoughts around what a systems framework can do for a hospital or for a flex program for that matter. And I want to start by saying this, it doesn't really matter which framework, it's just a tool. And tools don't improve things, people improve things, but these frameworks are valuable tools. And in the same way that there are times you just need a tool, you can't do a task or function without one. These are excellent things to help the good people in these hospitals do what they've been called on to do. So just a few advantages that I recognized in relationship to my flashbacks and remembering my own CAH experience. The document, the report mentioned the day-to-day trials of running a rural hospital. And what I remember is sometimes those can be minute-to-minute trials. You can be so overwhelmed with what's going on and the tyranny of the urgent that a good system framework can help you get beyond that. Any number of things can happen that just sidelines or upsets the rest of your day. But a framework to come back and pick up where you left off after you put out the brush fire or you squelch the crisis, and you can come back to where you are. That's what a good framework can do. It helps you avoid the tyranny of the urgent. It also provides a roadmap to move on from doing nothing just because it seems so overwhelming. It moves from the overwhelming to the manageable. And I've got to tell you, there's a temptation just to be so overwhelmed by something that there's an inertia that cannot be overcome. And just the decision to make the investment into a framework, the human resource investment into that, gives you that impetus sometimes to move on from doing nothing to doing something. It also allows us to focus on different areas such as financial, operational, clinical, simultaneously. Tracy, one drawback to being a pilot is that you relate everything you're talking about to flying an airplane. So if you'll forgive me on this, I'm going to give you just a little bit of insight from my life as a pilot, and that is when I entered instrument flight training. Now, just for those on the phone, that means learning how to fly the airplane without being able to look outside the window and see the ground or see where you're going, but flying it strictly based on the instruments. And what I noticed, first of all, is that I would be going along, think I'm doing fine, and the instructor would say, watch your altitude, and you're letting it slip. And I'd look over, and I'd be 300 or 400 feet low or high from where I should be. And I began to fixate on that altimeter. And when you fixate on one instrument, the rest of the thing just falls apart on you. And we have a tendency to do that in anything, but you can do that running a hospital too. You can become so fixated on one problem that the rest of them go. Using a framework allows us to do these things simultaneously. It helps us to focus on all these different important areas. And finally, it provides feedback. Once again, kind of the aviation overtone here. I'm reminded of the captain's mixed message that he shared with his passengers. He said, folks, we have good news and bad news. The bad news is we're lost. The good news is we're making great time. And so I think the fact that a framework can give us that essential feedback to know where we are in case there's a need for a mid-course correction or whether we're doing everything right and the call is for full speed ahead. So with that in mind, let me very quickly make a case why I think the interventions that you came up with are important, not only to quality improvement in critical access hospitals, but to the entire concept of framing rural health value in this environment that we find ourselves in. So by looking at your interventions in the major areas that you categorized, Tracy, the next slide there, is you mentioned these main framework areas. And it's no surprise, as has already been mentioned, that leadership was the first priority that came up. Now, about the leaders that are in these critical access hospitals in your state, by and large, they are very talented, intelligent individuals. If you look at them, they're leaders not just in the hospital setting, but they're leaders in their communities, in their churches, wherever. And they're sometimes the cream of the crop. But as I look back on my experience and I see what your interventions number 1 and 4, I can sum up much of my experience as a critical access hospital administrator very succinctly. I didn't know what I didn't know. Now, CH leadership development in your state is so important and so needed. And just make sure as you're working with these folks that you move beyond just this gathering up and talking about how important leadership is to some nuts and bolts, some concrete actions and techniques that you can share with them and that they can learn from one another. Make sure that there's plenty of room beyond the discussion of how important it is to some peer-to-peer help in how they go about it. Things are changing. Unlike any time, there's so much change going on now. Some days I just come to work glad I'm not still running a rural hospital. Yesterday's strategies will not meet tomorrow's challenges. And in fact, as I look at what's going on, many times past successes, in other words, doing things the old way that got you those successes, is probably going to be the number one determinant of failure in the future. Change is here, and there needs to be that adaptability. In the second area of community, customers, and population health, I just saw the importance of partnering with community and even others beyond your community as you're talking about looking for that statewide partner or that network partner. And then that's going to be especially true as things move more from silo-driven healthcare to more population-based models. Under the area that you listed as operations and processes, and I would even throw in that group with the strategic planning, I looked at your interventions number 5, 6, 7, and 9, and I see the importance of providing or arranging for direct technical assistance being so important, such an important role of your flex office, and especially moving communities forward based on a community health needs assessment. Now hear me again, such an important role for your flex office. And when I'm talking about this community health needs assessment, I'm not talking about the IRS version that they need to do for Form 990, but I'm talking about a robust, tough love, hard question kind of community needs assessment that's looking at these communities and helping them ask the hard questions and swallow the hard answers about right sizing and right servicing the future healthcare system in their community in order to provide for value and sustainability so that 10, 15 years down the road, they will still be there serving that community. Under the area of workforce and culture, your interventions number 8 and 10, this is so much more than just recruitment and retention of providers. This is about helping them create a change-ready, customer-focused culture in their hospital. And I just want to point out, it includes workforce satisfaction just as much as it does patient satisfaction. You know, employee satisfaction is so important. Your employees at these hospitals will either be your best friends or your worst enemies when it comes to public relations. And many times that comes from a sense of ownership, a sense of being heard, and being part of the decision-making process, so important in these hospitals. I'll just sum it up by saying this. As far as the entire webinar series, you did a great job. If I were still running a critical access hospital, I would see the kind of direction and support from my state flex office as very helpful, maybe even crucial to my survival. I appreciate everyone that's had a part in this and the opportunity to be with you today.
Thank you so much, Paul. It's really great to hear the validation of the work that all the great states are doing, and also to hear your perspective as a past administrator about, how we really truly are on par with this and with giving some really great direction, great ideas about where to keep going with the FLEX program direction, and also using a performance framework to support the hospitals and the state FLEX programs. Now I'd like to invite Christy Martinson onto the webinar. Chrissy is the Hospital State Division Director with the Federal Office of Rural Health Policy, and she spoke previously on a webinar in this series about using a performance excellence framework for the state FLEX programs. So Christy is joining us today, again, to revisit this topic and explore how FLEX-supported activities and state FLEX program operations align with the performance excellence framework. Christy?
Great. Thanks, Tracy. And good afternoon, everyone. I can't believe it's already at the end of this webinar series. It seems like we just started. So I'd like to echo the thanks that has already been stated by Tracy and Paul, but just all the great work that those who presented provided in preparing to help the rest of us learn, and for everyone who participated on the webinars and in the cohort groups with the sharing. I think, we didn't have the opportunity to have an in-person FLEX meeting this summer, but I think this is a good alternative to try and get at some of those networking opportunities. So in thinking about the FLEX coordinator position, you all are really in a critical position as we think about, I think we all know the picture of the shaky bridge at this point at the end of the webinar series, but times are changing and things are tough for hospitals as they figure out how to survive today, but also plan for the future. And so as a FLEX coordinator, you really are in a critical position where you're able to help set the policy for the state and provide technical assistance that will help hospitals get to where they need to be to prepare for the future. So really linking the goals of the FLEX program with the needs of hospitals in your state and thinking strategically about how you can align the limited FLEX funding, grant dollars, and then what other resources are in your state to help make as big of an impact as possible. So, we've been through some changes as well just within the FLEX program and changing a little bit, moving from more broad, general technical assistance type program to really adjusting to the demands in the current federal environment of needing to measure impact. So we've kind of gone over our own shaky bridge of sorts. And so you've had to step up a lot and try to implement some of the changes that we're coming down the pike, kind of building as we go with MDQIP and some of the other movement towards outcomes. But I think we are almost to the other side at this point. So we have put in a lot of hard work. So just recognize all of the great work that you've done as well. So thinking about what all of the performance excellence framework means in terms of the FLEX coordinator specifically, just to echo what Paul said in terms of the critical access hospitals, the FLEX coordinator role is also kind of unique, and so the performance excellence framework is the opportunity to just think through all of the issues that you have to deal with through the FLEX program and think about how you can focus on each of these different categories to help you better understand what your role is, where your needs are, and how to make things move from overwhelming to making things a little bit more manageable. So under the category of leadership, just a couple thoughts for that one. As a FLEX coordinator, you have a unique job. There's only 44 others in the country that have the same job as you. So really take opportunities to connect with other FLEX coordinators, since you really are, as a peer group, able to help each other out more than anyone else can. So whether it's the cohort groups that we had as part of this webinar series, your regional calls, or just following up with each other after questions or comments come up from a call and you want to find out more information. And also don't forget to look to the task for a resource when questions come up, whether it's information and resources on their website or engaging in the virtual knowledge forums as well. For strategic planning, I think this is a really important component of the framework and a way to help strategize what it is that you really need to focus on. So whether you use the Baldrige framework or some of the other strategies for planning out what your work is, both, on a day-to-day basis, thinking about what your priorities are and where you really need to focus your energies and your limited dollars, and then thinking for the FY15 work plan, thinking about it in terms of the 3-year project period for your grant, that it's more than just funding projects on an annual basis, but over the next 3 years, what are the big needs in your state that you need to address, and how can you meet them over the 3-year period? On the community, customers, and population health, thinking about what are the needs of hospitals in your state and working with the data that's available, whether it's FMT or if there's other resources in your state that have data around what hospital quality and financial status is. But also just getting to know your partners, the hospitals in your state, the systems in your state, other partners that are working with hospitals in your state. One of the things that I heard Susan mention in her comments was how she went out and talked with all the hospitals and had to explain what the FLEX program even was. So just thinking about how you message the program, where you can create stronger linkages within your state or even your region. One of the changes that's coming up is with the QIO program, so thinking about how you can re-engage and build partnerships now that those programs have changed a little bit as well. For workforce, it's just thinking about within the FLEX program, what are the needs for hospitals in your state, and what does that mean in terms of what training you might need for FLEX program staff to be able to meet the needs for managing the FLEX program, or what does it mean in terms of what types of activities you might need to contract out to meet the needs of the FLEX program goals. And then with the process for improved outcomes and then outcomes and impact and measurement, just thinking about what is the best way to address the needs within your state and fund activities that can help hospitals improve, whether it's around quality issues or financial and operational issues. Again, this is an opportunity to think about what other states might be doing if you aren't quite sure what to do. What other resources are there in your state that you can tap into? And then looking at the FLEX monitoring team reports that they have on best practices around particular interventions as well. And then for just measurement, feedback, and knowledge management, making sure that you're looking at the information that comes back in, sharing that information back with hospitals, sharing that information with state partners so that you can continue to build on the successes that you have had, engage a broader range of partners, and continue to collaborate and have a big impact based on the limited FLEX dollars that you do have. So those are just some key takeaways. And we're going to be looking at the Performance Excellence Framework in HSD as well, just to see how we can better structure the work that we're doing, looking at all these different categories. So hopefully we'll continue to have conversations about this and how we're all have some good takeaways from this webinar series. Thanks, Tracy.
Thank you, Christy. And that's great that the framework is kind of transcending all the work that we're doing, be it being implemented in a critical access hospital in the state FLEX program or also at the federal office of health policy as well. That's great. And I love the perspective that 45 people have the role of a state FLEX coordinator. What a unique program and what a unique opportunity to work in this field. I just think it's so inspiring and so exciting at times. And so we have about 8 minutes or so left on the call, and so I know you're all really curious about what happened with Community Memorial Hospital. And so we'd like to close the loop with sharing a little bit about what's happened with this case study hospital 1 year later. And you can read a lot more about what's happened with this case study hospital in the final report. But this hospital story is really partially based on a real rural hospital journey from crisis to excellence. And today this hospital is among the top quartile of critical access hospitals in quality and financial performance. And so the outcomes that we're talking about here today and in the report are fictitious, but they're based on the FLEX program recommendations and on many of the FLEX recommendations that are actually carried out in the real hospital that's related to this case study hospital. So I'm just going to kind of do a recap quickly of some of these things. And again, you can read more in the final report. But the State Flex program met with the hospital leadership, and the physician leadership and the board was also brought in so that everybody was kind of together on the same bus and hearing the same sort of information. They reviewed data, and they all agreed to a multifaceted plan. And that plan included support from the State Flex program with some work plan efforts that were already going on, with some additional funding that the State Flex program was able to allocate for the Alexis Hospital, but also support directly by the hospital itself, realizing that though they had limited resources, be it time or personnel, that they really needed to dedicate some efforts into kind of righting their ship. And they were able to collaborate with other partners in the state as well, including their state hospital association for other resources. In the area of leadership, they really focused on board education and prioritized that, and it was brought into every board meeting. The physicians were integrated into the board and into the decision-making process. They didn't hire a new administrator, but actually reached out to another CAH for a mentorship program. And the hospital leaders were provided some trainings and the opportunity to attend some state conferences and network events, and some of that travel then was supported through the State Flex program, as I know that many of you are doing as well. In strategic planning, they really moved from putting out fires to having a compelling vision statement with clear, measurable strategies that was communicated to all the employees in the hospital. And this really empowered the employees to become understanding their role within the hospital, but really becoming ambassadors within the community as well. They developed a comprehensive business plan, and that became the primary emphasis of the hospital's leadership. And really that dramatic change allowed them to convince the Regional Economic Development Authority to loan the hospital $500,000 to finance their turnaround. And the authority was previously approached, and the hospital had then been denied, but because they didn't have a solid business plan as well. And so through the assistance with some technical expertise, they were able to put this plan together and secure some funding to really help them stay afloat. They conducted a community health needs assessment and really reached out to other providers in their community to create an ongoing dialogue and get out of their own walls, kind of as Susan was talking about, to become more of a community member. And through those initiatives, they were able to cut out migration rates by 25% during the first year. And they focused on some marketing and significantly increased the volume of outpatient and inpatient services. They implemented HCAPs and did some customer service trainings, and were able to move up along the ranks of percentile for HCAP scores. And in preparation for population health payment methods, they kind of took population health management to heart and began within their own walls with a wellness program for their employees. And so they didn't have any measurable outcomes after the first year of implementing these interventions, but the staff did give their employee programs high marks in their employee satisfaction scores. They were participating in MBQuip before, but they were just kind of starting to report data, but now they're participating in the statewide quality and financial benchmarking program that was initiated through the State Hospital Association, and they're a member of that existing network. They use a balanced scorecard to record and communicate their quarterly progress, and education was provided to managers and leaders on how to use the data and how to drive performance. And really that left their hospital with measuring what matters most to them and making sure that the information that they're measuring is either actionable or data that's required for some state or federal government for compliance. Recognizing that they needed some assistance with culture change and change management, they hired a national firm that instituted a prescribed program to build individual accountability, some change readiness, and customer service excellence focus within their employees. They partnered with their physicians, and they started benchmarking provider satisfaction scores as well. And then focusing on operations and processes, the State Flex program allocated funds for them to provide direct technical assistance on revenue cycle management, which helped them improve their financials and increase their revenue. They were able to reduce their days in accounts receivable from 101 days to 53 days in the first year, and that brought in an additional $1 million in revenue. That really helped them to be viable and to invest in some of these other opportunities that they had going on. They had some business office process improvements, quality improvement initiatives were integrated in, and they introduced lean into their environment as well. And so, although this sounds like a lot of different activities, most of the activities themselves had a systemic impact on all areas of the hospital. So digging in and providing resources in one particular area ended up benefiting other areas of the hospital as well. And they were able to realize all these different outcomes and impacts that are noted here on the screen in front of you. As I mentioned previously, we put together a final project summary report. The link is provided here, and we'll send the link to you in an email as well with the recording from today's webinar. But in that report, you can see more of a description of what happened with this case study hospital. There's an overview of the recommended interventions and where they fit in with the different areas of the categories of the Performance Excellence Framework. There's some quotes in there from the cohort discussions and things that you all said about either what the case study hospital needed to do, why an intervention was important, or what you might